Great job to the TBI free. So we have three very cool lectures, one in person about new motion preservation approaches. I thought that was really neat. Dr. Armen Khachatryan is going to talk about something called Motus, M-O-T-U-S, which I think was referred to by Tony before, and that is both decompression from posterior approach and realignment with motion preservation. I still don't understand the mechanics of this. Dr. Armen Khachatryan, who is watching the eclipse in Utah, who's a faithful attendee and faculty, usually sends his regards, but he recorded it. So let's see this. And this is, again, a guy who's part of the FDA trial.
This is the 5th edition of SSF Advances in Motion Preservation, and it has become one of my favorite meetings to attend. But this year, I unfortunately cannot be there in person because of camping plans in southern Utah with my family to witness the solar eclipse. My intent was to present live, virtually, but since you're watching this pre-recorded presentation, what this means, as you sit there in Seattle, I do not have an internet connection where I'm camping. In any case, let's get this going. So what makes Motus device different from any other implant that we currently have in the spine world? It's not just a disc or facet replacement, but a total joint replacement for a given lumbar segment. It is intended to replace the function of both the disc and the facet joints. The ID trial is nearly 2/3 done with its enrollment. And colleagues who know me, they will tell you that I'm not a person who usually engages in superlatives. But if the results from the ID trial replicate, let alone surpass the pilot data, this device will change the face of lumbar surgery as we know it. So what are some of the unique features of this device? It comes with a proprietary vitamin E-enriched, highly cross-linked polyethylene, which to my knowledge is the only one within the spine arthroplasty world at the current time. Also, unlike some of the other spine arthroplasty implants that are currently on the market, the poly is not snapped onto the cobalt chromoly end plate, but it actually poured onto the implant during the manufacturing process, thus reducing the likelihood of any backside wear. The bottom end plate is secured in place with a self-drilling screw. And prior to implantation, a part osteotomy is the integral part of this procedure that not only prepares the vertebral bony bed for the implant insertion, but also allows for sagittal realignment when needed. And we'll show you what this osteotomy looks like in just a few slides when I speak about the surgical technique. The left and the right implants are inserted along the axis of the pedicles through a pliff-like approach that is very familiar for all spine surgeons. The implant can accommodate a total of 18 degrees of motion with 10 degrees flexion and 8 degrees of extension from its neutral position. So what does the patient population look like for this implant? A single level lumbar pathology that requires instrumentation, even though stenosis requiring decompression can be done at multiple levels. Symptomatic lumbar degeneration with or without foraminal or lateral recess stenosis. Up to grade 1 spondy, including lytic spondy. And what makes this implant different from other lumbar arthroplasty implants currently on the market is that facet degeneration is not an exclusion. Someone like this patient would be a great candidate with grade 1 spondy, significant lateral recess stenosis, facet gapping seen on this axial C2 MRI, and presenting with low back pain and radicular pain having failed non-operative measures. So what are some of the key exclusion criteria? Grade 1 spondy, compromised caudal pedicle because this is where the inferior end plate of the implant resides, DEXA score of worse than -1, and finally rotary scoliosis. So let's take a brief look at some of the biomechanical and alignment parameters. In the left-hand picture, you see a spine with normal sagittal balance with 54 degrees of L1 to S1 lordosis and with sagittal vertical axis of 0. In the middle picture, we see a degenerate L5-S1 segment with loss of anterior column height, which leads to kyphosis or loss of lordosis, right? And then L1 to S1 lordosis is at 28 degrees and SVA falls 8 centimeters anterior. In the right-hand picture, we see the spine with a Motus implant restored back to normal sagittal balance with SVA of 0 and an L1 to S1 lordosis at 35 degrees. So you may ask, well, how is this possible? Well, it is done through a combination of anterior column height restoration and a posterior column osteotomy prior to the implantation of the Motus implant. And I'll show you quickly how this is done. In the late 80s, Bridwell and his colleagues published average numbers for normal lumbar lordosis. As many of you know, nearly 2/3 comes from the bottom two segments. On the left-hand side, we see a normal spine, and on the right, a degenerated lumbar spine with loss of disc height and segmental lordosis. So how do we create a normal disc space at the L5, S1 level, for example? Here's how you do it. If you measure the wedging in the L5 vertebral body, it is 10 degrees. Therefore, if we perform 13 to 15 degree osteotomy along the pedicles bilaterally as measured in the right-hand picture, and add the anterior column height with the Motus device, we would regain the 25 degrees of lordosis lost at this segment because of this degeneration. And this angular osteotomy is achieved with the greatest removal of the bone taking place posteriorly, some in the middle and none anteriorly, and this is done with a powered osteotome that comes in the 3-spine set. The other parameter to keep in mind as it relates to the biomechanics is the center rotation for each lumbar segment. And with the exception of the L5-S1 segment, this center rotation resides just posterior to the midline of the disc space at around 40-yard line. And in the case of L5-S1, it resides even further back at around 35-yard line. The Motus device is designed and should be sized and positioned within the disc space to replicate this fulcrum point for proper postoperative biomechanics. So next, let's take a quick peek at the instruments and the implants. Single instrument tray is provided with all the tools that you will need for implantation. This includes various size height and depth trials, rasps, keel cutters, implant holder, and handles. Implants come in 3 different sizes, small, medium, large, and 5 different heights from 11 to 15 millimeters. And now let's jump quickly into a surgical technique, and we'll do so with a brief 90-second video. So here a patient is placed in a prone position on a Janssen table matching the standing lordosis. Gill laminectomy is completed. After radical bilateral discectomy, utilizing this long rasp, we next complete the desired amount of end plate and pedicle osteotomy of the superior end plate of the caudal vertebral body. Then for the inferior end plate on the cranial vertebral body, the short reciprocating rasp is used to smooth the posterior lip of the end plate. Next, as you can see here, we're going to move on to the height trial, which come in the 5 different sizes. And this is followed by the depth trial with the appropriate sizing to get the implant to the 40-yard line. This is followed by cutting the inferior keel, and this is done in line with the actually, next we cut the superior keel in line with the inferior keel. And at this point in time, we're ready for the insertion of the implant. And this is finally secured with that screw to the bottom end plate. And you can see here that the fulcrum of the movement is at that 40-yard line. And it's the convergence of the implants that provides that initial provisional kind of stability to shear forces both in axial as well as front to back and lateral planes. So, a very common question that almost every surgeon who sees this implant and technique asks, and that question is the following. With the complete resection of the facet, how can this implant withstand the shear forces during normal activities of daily living? We see the assumption that the load on the lumbar spine acts in a vertical direction results in a serious overprediction of shear forces on the segment. You see, if all soft tissues, including all muscles and ligaments, were removed and vertical load was applied to the spine, let's say at 45 degrees of sacral tilt, then the shear to compression ratio would be 1. For a sacral tilt of 60 degrees, that shear to compression ratio would be staggering 1.7 to 1. But this is not the case. And that's because of the erector spinae muscles, which through the course of normal lifting will apply compressive forces, thus negating or neutralizing the shear forces. In 1995, Hahn, along with Joe Weinstein, published this landmark article looking at compression versus shear loads in the spinal structures during lifting. As you can see, with soft tissue structures intact and functioning, with dynamic motion without lifting any external weight, compression load on the spine is about 2,500 newtons, and the shear load is actually about 500 newtons. Therefore, shear to compression ratio is 0.19. With the added weight of 90 newtons, which is about 20 pounds, or 180 newtons, which is about 40 pounds, the forces being applied to the spine are increased, but the shear to compression ratio still remains low at 0.18. And this is the reason why this diagram is inaccurate. And this one on the right shows that during lifting tasks, the primary load component is compressive, and maximum shear load is about 20% of the compression load. And that, my friends, even with complete resection of the facets, is how this elegant implant and technique functions perfectly well. And to conclude, here's the pilot data that was used for FDA submission to initiate the IDE trial. The data was published in Spine Journal in September of 2020. ODI improved from 45 at baseline to 8 4 years after Motus device, and average improvement at 1 year or later postoperatively was about 77%. The SCB, or the substantial clinical benefit, which is defined as greater than 18.4 points or 36.8% improvement from the baseline in ODI, and this number is 59% for TLIF and 87% for the Motus device. The MSS, or the minimal symptom state, is defined as ODI of less than 20, back and leg pain scores of less than 20 as well. Again, 34% of TLIF patients, in contrast to 76% of Motus patients, succeeded meeting this stringent criteria. And finally, for the MCID, which is less stringent than the SCB, is defined as 30% reduction baseline ODI, 72% of TLIF patients versus 87% of Motus patients successfully met this criteria. So, again, I believe I'm getting pretty close to my allotted time, and we'll stop here. I unfortunately will not be able to answer your questions live, but we'll be happy to do so through email. Please feel free to email me. And again, thank you. And you all enjoyed this great art.
Thank you, Armen. Enjoy the eclipse. So Dr. Mike Janssen is, because Dr. Khachatryan is not able to answer questions live, Dr. Janssen has kindly accepted the task to be our moderator. He's a internationally renowned spine surgeon and one of the pioneers of disc arthroplasty. Mike, can you unmute yourself? Are you live?
Yes, I am. Thank you so much. I guess the first question is, does anyone in the audience have experience with this technology or involved in the clinical trial?
No. Anybody? Nobody.
We've only seen one patient at TBI with a failure.
Wow. What was the failure, Rick?
Do you remember, Jack, we had seen, or anyway, it looked like the, yeah, it was instability, basically.
Sure. You know, we get so concerned regarding even a non-translational osteolysis or pars defect that we may find incidentally after remobilizing a disc, thinking that there's posterior element failure and therefore the shear forces are too great. I find it amazing how this particular technology completely removes the posterior elements. And, you know, the posterior capsules, it looks like it still leaves the interspinous, supraspinous ligaments, but yet the lamina and the facets are gone, the capsules are gone, the PLL is removed. So I find it amazing that it has enough inherent stability to provide motion and treat that segment of the disease.
Mike, knowing very little other than what I just saw, I'd also worry about subsidence inferiorly, where they're cutting into down to the subchondral bone at least, and then have footprints that are significantly smaller than we use on our anterior implants, loading onto that area that's down to lower than high cortical bone. So I don't know if that's an issue either, but you know, they got 4-year data on their pilot set of patients. So obviously that would have stuck its ugly head up if that was a big issue.
The other point I would make,
Jens has always taught me, we always worry about how you get implants out when they fail. And to have this wrapped around and underneath the pedicle, the nerve right there, and being able to retrieve this could be a challenge.
Well, and not only the one case that we did see that failed, Mike's point, very well taken. How do you get stuff out around scarred nerves and things like that? And the salvage is turning a one-level case into levels above and below because there's no fixation left at that level. So you turn a one-level problem into a multi-level problem when it fails.
Sure.
You know, and I hate to be a naysayer because, you know, we all are invested in motion preservation, but it just doesn't seem like the long-term follow-up, although they have, as Jack said, 4 or 5 years of their initial pilot. I'd like to see the final results from the trial, though.
But he didn't mention, is it being randomized to a TLIF? Is that what he mentioned? Is it some sort of
I think so.
clinical trial? Okay, okay. And now we haven't, one more before we go on to endoscopy. How about just in general facet replacements? Because when I first looked at this, I didn't, you know, understand the technology, but we sure haven't seen a lot of dynamic, you know, Denis's type things or general facet replacements. And we didn't really have anything in this new motion approaches for that. Is anybody involved in any of those current technologies or aware of what we have being investigated in North America currently?
Tony has a question to you, Mr. Viscogliosi. We talked about it, and we'll actually talk about some of those things in the spinous process section. So the last section, we have Todd Altman here also. So that's in the last section, but that's actually not new anymore. It's kind of almost mainstream except for facet joints. But Tony has a question.
Thank you, and thank you, Mike, for moderating this session. It's nice to see you on video. Not being a surgeon, my question is, with the volume of tissue removal, both hard tissue and soft tissue, what occupies that space post the procedure? What happens in that space? Because there is no space in the body that becomes void of that has emptiness. So what do you think happens there?
Well, it's nice to see you too, and thank you so much for that, for all your pioneer work. I view it probably very similar to doing a complete facetectomy and doing a big TLIF, or what we did as PLIFs. It fills in with fibroblasts, the nerve scars in. It's an area that makes it very difficult to ever get back to. I would worry, what do I do when these patients also have radiculitis post-op, either from, you can only push the nerve up so far up against the pedicle, or it socks itself in fibroblastic response and you can't move it around. You know, we always learned a long time ago that there were 2 types of operations. You operate for back pain and create leg pain, and you operate for leg pain and create back pain. And that would be the first thing that I would worry in my hand with a case like this, especially when we're trained so much to do non-fusion and most minimally invasive type approaches. It just seems very destructive to do something like this and try to preserve the motion at the same time. I agree with you.
Thank you.
Great. Okay, so let's move, and then we'll see what we have left for time. And now we're going to move into something else that I think is very innovative, and there's a small sub people that have great talents in that, and take a look at lumbar endoscopy type procedures.
So Dr. Ghazwan is actually here from Baghdad. So
Fantastic.
that's our Ghazwan Hasan. He's going to come up. Fantastic honor to have you here. Thank you for joining us. And I found it particularly compelling to hear his experience, because we in our country struggle with spinal endoscopy, as it is not reimbursed, very expensive, and right now still is looking for a role, whereas other countries are running leaps and bounds around us. And here's a colleague who we know very well from his time here in the US, and he's doing spinal endoscopy in Baghdad. So curious to hear your objective thoughts.
Yeah, first of all, I would like to thank you all for inviting me for this amazing event. And the good thing that I'm not alone, or that's facing a problem whenever we want to introduce a new, let's say, technology or techniques in the country. We discussed it before. Still in US, there are some limitation. And this is my disclosure, which is nothing relevant. And I will start with this case as Daniel Rowe presented before. I think that's one of the cornerstone steps for applying the minimal invasive and endoscopic spine in such cases, which is a far lateral disc at the level of the 5-6, and this is the CT, which is indicate a soft disc, and this is the what I did actually by doing a posterior cervical discectomy by the endoscope, and this is the lateral here the lateral, and here the medial, and this is the root, and this is the site of the disc, and simple by doing discectomy here, and we remove the disc only without any intervention to the motion, which is, I think it's some sort of motion preserving. My talk will start. That's why we all thinking about, we have to think about the endoscopic spine, and how can we, I started actually in Iraq, and how I explain the indications, and also mastering the level of the endoscopic spine. This is one of my case actually, which is she's about 32 years old. She had a previous history of 2-level laminectomy and presented with recurrent disc. I planned at that time with 2-level fusion, as you see in such X-ray, and this is 3 years ago. And unfortunately, she returned back, presented with me with radiculopathy and some sort of neurogenic claudication, which is, this is her MRI after 3 years. And whenever I saw such picture, I start to think with this type of let's say X-ray, that's in most cases that they started with single 2-level, and you cannot imagine that every time whenever you attend an event in the spine, you will see such cases. So I start to think that then I'm in this level, that's I start to refuse, but how I change this philosophy and being refused to fuse. And I think that's motion preserving is one of the idea. So why endoscopic spine? I think from my perspective, that's finding a solution for the current problem. This is the what we did before, open laminectomy, just to remove the disc. And imagine the soft tissue damage that's occurred posteriorly. And also, it's a lifetime progression. We started our life doing open laminectomy, and then progress to the microscopic discectomy, and we for fusion also we start with the posterolateral, and nowadays there are many techniques available, that including the ATP, ALIF, OLIF, and the others. So we have to do something new, and Antoni presented an amazing talk in the morning. That's we following the regenerative spine. So we start with the fusion. Now, motionally preserving. Tomorrow, we will think about regeneration. So I think that's another point. That's, for me, it's a personal achievement. So because every year I put a goal, that's I want to achieve something new in my career. So the endoscopic spine was one of it, and it's innovative. That's, you know, in my country, most of the people, they don't like to put an implant inside their body, and I think it's global. So we have to find the solution as the cases presented before. And this is one of the technique that's becoming rapidly growing, which is called a UBE technique, unilateral biportal endoscope. So how can we start it in Iraq? Actually, we have concerned barons. That's a private will be much more easier to invest, because you don't need sophisticated steps to applying this in the government hospital. In the government hospital in Iraq, they are busy with the trauma mainly, and because and also they lack to the advanced infrastructure because of the situation that we lived before. And also the degenerative is a common in the private, so it's very important. It's very, let's say, sexy item that we can invest in the private. And also when we saw the literature and the support, there are many topics about the endoscopic and how this technique that expanded in the last 10 years from simple discectomy, and nowadays they are talking about a fusion with different technique. And also, as I mentioned, it's a technique that can solve many problems in the spine, not only in the lumbar spine, but also in the dorsal and in the cervical spine also. But on the other hand, we don't have assurance company that can let's say support, so the patient pay from their pocket in the private versus totally free in the government hospital. So it will be not uneasy to convince the patient, and we all know that the financial problem. And also, we don't have advanced spine surgeon in my country. We have a government hospital, we have a private hospital, but we lack to the advanced centers. Also, we don't have a support from the company that's can bring the sets or the instruments or make a good investment, because for them it's let's say a virgin market, and they don't have a full data that can access and put a plan for their future work. And importantly, that we don't have a backup surgeon for these new innovative techniques that we can let's say work with them to get this new technique. But as I mentioned, the UBE is one of the technique. I like it for lumbar spine, because almost we don't need sophisticated instruments that the uniportal does need, and it's you can do the surgery with the simple basic sets. And I did this surgery when I was invited in Pakistan as a faculty, and believe me, they don't have any sets of the UBEs. We complete the surgery using the the basic sets with the arthroscopic scope from knee scope, and one let's say Khachatryan for the shoulder. So we complete this surgery without any without any sophisticated, which they like it, and they emailed me later on that they already start this technique to do it. And again, it's better visualization. This is one of the video, and you can imagine that's how the field is too big that you can let's say see the clarity using the pictures. And also shorter learning term. Although I have my personal experience in it's shorter term when it's compared to the transforaminal, but it's not shorter when it's compared to the interlaminar. Interlaminar uniportal is the shortest learning curve that I experienced. And also varieties of the indication. These are some of the indication nowadays they are using for UBE, which can be solve most of the problem. So among these circumstances and the data, how can, let's say, overcome the limitations and start such technique in my country? I went to many training. I was in Korea and attending some courses after that, and then I started to do to select the cases. This is, I think, that's one of the cases which is ideal to start with a simple sequestrated disc 5S1 or 4-5. And also in my initial cases, I put a plan B. I came from a tubular side. Which is I did many cases in the tube, so I put the tube as a plan B, and I faced struggling in the initial steps, and I shifted to using the tubular in my initial cases. And also the most important point that I have a common groups, and sometimes even I contact Professor Chapman to ask him and let's say consult him how can we solve this problem, because I'm reviewing my initial cases, the video. So what was the struggle in this surgery? So I contact the expert to ask them. And the most important point, that's having a backup surgeon. And this is Anand Kavi, who is one of the experts in the endoscopic spine. I invite him to my country, and we did some initial cases as a backup surgeon with him. And also, this is the endoscopic, let's say, step ladder that's, let's say, who Kim presented. That's you have to start it with the simple cases as endoscope, and then extend the indication to the stenosis, and then end up even with the fusion. And nowadays they are talking about the fusion, whether it is through the transforaminal or even the transcambian fusion. Some guys, they are doing it. So I extend this and I apply this concept in my let's say career started with disc and then expanded to the stenosis. And then this is one of the interesting cases about synovial cyst. And then I apply it even for recurrent disc, because one of the pitfall and the argument that's the endoscopic spine has a large incidence of, let's say, recurrent disc. This is one of the cases that operated before by tubular, and then I did a revision by the endoscope and remove it. And then this is another case that's of one, as I mentioned before, I did for her a decompression at the level in order, because I discussed depth with the patient, and she was agreed that she doesn't want to extend her instrument, and she's only complaining from, let's say, neurogenic claudication, and apply this technique. And then after that, I have a series of cases of treating the spondylodiscitis by just debridement and putting a percutaneous screws. And the most advanced technique that I'm doing nowadays is spondylolisthesis and doing endo-TLIF using the endoscope, which is for me is much more easier than MIS TLIF. So I will end up with this step that I put it in to decompress the spine endoscopically, and these are the videos that you can imagine. The first, the field visualization and identification of the spinolaminar junction, then doing laminectomy using either Burr or Kerrison's, and then identify and resect the base of the spinous process. Then you go with ipsilateral and then contralateral, lateral recess, and then end up with foraminectomy on both sides. And if there is a disc prolapse, you can even do a discectomy, and then that. Then we coming to the level of the mastering, the level, as I mentioned, increase the indication level, showing your work as I'm here, and also training. Change from trainee to the trainer. This is one of my friend came to start and learn the technique, and this is the good result that I get it. These are my fellow that they did last week the first case for them as a UBE, and I think this is a big achievement and widening of the indication, and the take-home message that's build your setting based on what you have in your circumstances, and start with a simple, straightforward case, and then after that, change the level, put a plan B and ask for expert. This work for me very, very, very good, and measure your progression, because this is a very important in your career. And thank you.
That was excellent. Thank you so much. That was outstanding. And just for your sake of time, because I know where you're at with the schedule, let's hold our questions until we finish the next from Joe Cheng on really now summarizing some of the key things we've been talking about, both in the lab and not, on the biomechanics of these motion preservation and how that really impacts on some principles. Okay, Joe?
Great. Thanks, Mike. Thanks, Jens, and thanks everybody for inviting me to give this talk. You know, there's been a lot of talk about biomechanics and really a big fundamental aspect of motion preservation and really artificial discs. I'm going to go over some of the concepts of biomechanics and hopefully be able to wrap up some of these principles for a lot of the devices and approaches that you've been hearing about. Nothing is closed, but I did get an RM for a talk on surgical site infections from J&J. When we talk about spinal biomechanics, really we're talking about a lot of different things. And in reality, when we talk about motion preservation, it doesn't come in isolation. It actually has to do in relationship to forces. And at the end of the day, it's really about the energy. Things don't fail because they move abnormally. Things fail because of excess energy, i.e. trauma, excess kinetic energy. You know, you get the picture of why this is so important. And it's because of these various aspects of spinal biomechanics that you're hearing about these devices that you kind of realize that they're really different in their own individual ways. So when we talk about preventing adjacent segment degeneration for the disc, I would actually argue that this isn't the goal of artificial discs or motion preservation. It's actually about understanding or replicating the normal spinal kinematics and kinetics of that segment. So even cases like this where you see these two devices put in, you notice that the patient lost lordosis, lost really the ability for normal motion, and so certainly would not have the same, and this patient did not have a good result compared to understanding that. And you're learning this with deformity correction and understanding normal loading of the spine through that. I always use the example of it's almost like trying to pick the best fishing lure. You're really creating artificial lures. And when you're doing that, it isn't so much as coming up with things out of the blue, it's really replicating the really what the natural component of what you're trying to replace. So at the end of the day, it's really about the biomechanics. And when I say biomechanics, I'm only talking about specifically a force deflection curve and the energy underneath the curve, which is a first order integration. And so similar to things like injuries to the disc space at C5-6, that just happens to be the center of rotation, which is why it's the most common level to be injured as far as, say a teardrop fracture for a C5 teardrop fracture, but also for disc degeneration overall. This is a video. I used to run the biomechanics lab at Vanderbilt, and this is just a video of some of the work we did looking at 3D kinematics, where we did CT reconstruction overlaid it onto a 30 frame per second, live fluoroscopy to be able to create a model for motion. And the video unfortunately isn't playing, but because of that, we were then able to replicate and really study the loading pattern, that is the kinetics of the kinematic motion overall, really the load bearing based on the different types of devices and really how they affect the surrounding spine. And what you realize is that the kinetics are different at each level. And you're like, well, that makes sense. A question before about L4-5 versus L5-S1, certainly things like shear loading, sacral slope, what we call slip angle, these are all very common concepts in biomechanics that we use in surgery. And so assuming that the loading pattern at C3-4 is different than C6-7, and you're going to be right, same thing like in a lumbar spine. One of the challenges that we have when we're looking at trying to get some of this data, though, is really the utilization of this. And as Jens alluded to with endoscope, a lot of times surgeons will only be able to do procedures that they get paid for or reimbursed for. And so this is 22856, a CPT code for cervical disc arthroplasty as an example. And you notice that this continues to grow, which is why we're seeing a lot more interest in cervical disc arthroplasty, because a lot of times if you look at the site of service, you can do it in the outpatient center, pass-through payments, things that really support that. Lumbar spine in the Medicare population is a little bit more difficult. And then here's the data for that, where you notice that it's a very low utilization. And a lot of it is that there's almost no evidence of outpatient or HOPD performance of lumbar arthroplasty. In 2012, believe it or not, there was an attempt to do that. That was why I put this 2012 data there. But obviously doing A-lifts or rather lumbar arthroplasty in the HOPD setting or ASC isn't something that's been readily adopted overall. So when we're looking at some of these, the empiric data as far as how we use these devices and what's available to us, like right now you heard from, Jack saying that there's only 2 devices out there. Some of the reasons you have to think about it is that sometimes you have to think about what's going to be the best devices for what you're trying to do. This is just an example of an ACDF that failed with subsidence, and a lot of times we think of something like this being acceptable or something that's expected. But in reality, this is just a complication of linear forces. So for example, if I showed you this film and told you that these were all variable angle screws, that the carpentry took out the cartilaginous and bony end plates of the vertebral bodies, and therefore the cages subsided, you probably wouldn't be very surprised, especially if you over-distracted overall. And that's going to be very similar to artificial discs as well. And this is just an example of subsidence or basically load failure of that by not understanding the needs of the biomechanics of what has to keep that disc in place, as was alluded to in some of the earlier talks. Forces, if you really think about it, the difference between a force or a vector and a scalar is really a direction and a magnitude. So here you have a magnitude of force, which goes down. And as you know from Newton's laws, every action, there's an equal and opposite reaction. And that's really what linear spine force is all about. The problem is that when we talk about forces, most of us think about quasi-static. So when you look at even dynamic X-rays, they're really nothing more than static flexion extension films. That is static films with the head position in either a flexed or extended position. That's quite different from quasi-static loading compared to dynamic loading. So kind of like if I took a book and put it on a styrofoam cup and it holds, you're not surprised. If I drop the book a centimeter above the styrofoam cup and it breaks it, you're also not surprised because the loading is different. And unfortunately, people load dynamically. We walk on an average about 4 to 8 hertz. So therefore, we have a dynamic motion that loads the disc spaces differently, again, based on the level and the amount of weight that we have over it. This has been seen over and over again. And one of the things, especially in the cervical spine, the lumbar spine, I'm sure is the same way, is really the surgical exposure is a key variable. So for example, different disc devices based on the width will require different amounts of resection of the uncinate joints in order to place it. Now this helps with with the results, for example, with nerve decompression and therefore the radiculopathy, but it also talks about the differences in inherent instability once you finish resecting these things. The uncinate joints are a key piece, and this is also why people still do anterior cervical discectomies without a fusion. This, again, is just Medicare data showing that there are still a handful of surgeons in the U.S. that continue to do ACDs alone versus using what we use as a combined code for ACDFs, that is a CPT 22551. And if you think about it, a lot of it has to do with the uncinate joints, the joints of Luschka. As long as they're intact, it's almost like making a little window in a can, where as long as the side wall is intact, they really don't create a lot of the kyphosis that people talk about. On the other hand, if you start resecting the uncinate joints, then all of a sudden things like, kyphosis and even over distraction becomes a much bigger issue based on what you resect, as you would expect. And this leads into the concept of distraction when it comes to artificial discs. We know the complications of tensile forces when you have things like disruption of the tectoral membrane or the extension of the PLL with AOD, but you also see this also with failure of artificial discs and extension. It's also based on the type of, contact or really the insertion component of the disc itself. And if you think about failure and extension, like for example in trauma, this would be a B3 injury where if you took down the uncinate joints and really violated the lateral ligaments of the joints of Luschka, you can expect that to be able to distract easier. If you did this in a cervical kyphosis, you would just call that an anterior cervical osteotomy, which is what you have to do to be able to get that reduction of kyphosis or open that up. If that's the case, then the type of fixation that your artificial disc has certainly will be a key variable in how well it holds. So we also talked about horizontal loads like shear translation. And we know this from example, just things, these are failure modes of artificial discs in translation. But we also know this, for example, with our anterior cervical fusions, the various types of plates that we use with fixed angle screws, dynamic screws, lateral, variable angle screws, or translational dynamic. For example, with patients with C5-6 perched or jump facets, that if you do a dynamic plating with that the shear loads will cause that to fail typically 25% of the time based on the paper from Larry Koo, versus places where you have locking plates, and that's the study in Canada, where you have a much lower failure rate because you have a much better biomechanical stabilization across that segment. And this is also a reason why the different artificial discs available actually have different properties, as you can imagine. So some of the motion is constrained, some of them are actually unconstrained. And so the type of stability that you need for that motion segment is going to be different based on, and where it's going to, how well it holds will also be based on the type of implant that you choose. And that's the same thing with fixations. Things where you have keels versus, bone ingrowth or milling or screw fixation has different strengths of fixation, as you can imagine. For the orthopedic surgeons in the room, you can imagine when you're talking about things like plasma spray or centered beads or various types of bone ingrowth or using various types of non-congruent screws, you will get different types of fixation for the bone, and then therefore different amounts of stability or strength for your implant. And this is very similar to when you pick, cervical collars to hold the neck, where if you look at the various ranges of motion, it actually varies. So you can imagine if someone has a hangman fracture in a short cervical collar, the collar sits below C2 and won't stabilize that as well for shear loading. And that's the same thing with your artificial discs as well. Well, is there such a thing as rotational forces and curved force vectors? Because we always talk about things like deformities. The answer is no. It's really about spinal moments. And again, this is an important concept to remember, is just force times distance really creates that moment arm in an angular situation. And when we talk about torque, it's nothing more than a coupled moment. And so this is just my example from before about a teardrop fracture. Why it typically happens at C5 and why it typically looks like this is because that just happens to be the center of rotation with the head in a flexed position when you have the equal and opposite reaction of the head being driven down by the weight of the body. The problem is that there's a lot of common biomechanical misunderstandings. So force times distance work in a linear setting, and you can kind of imagine that, but kind of like using kilograms as weight when it's really a representation of mass. The problem with angular motion with artificial discs, a lot of people forget that you have to multiply by the moment arm by radians, which is unitless, in order to figure out how much work is actually being applied to that disc, which could cause it to fail. So it's not a stress strain curve, which really only happens with homogeneous properties or materials. Heterogeneous properties like human body, we actually want to use the force deflection curve where the area underneath the curve, very similar to the modulus of elasticity or the stiffness, which is the most linear part, but the area underneath the curve is actually energy. If you think about it, that's really what it comes down to, and why things fail is that we did not predict the amount of energy that's going to be transmitted to that joint and what type of structural integrity is needed to mitigate that. As was alluded to before about Dubosset's cone of economic function, we are getting back to understanding biomechanics and deformities and really the understanding of how we get better patient results from understanding the idea of minimizing the moments and therefore minimizing the energy that's transmitted through the constructs that we use. Similar to positive sagittal balance or a truncal shift, if you think about it, a lot of our deformity surgery is nothing more than lining up force vectors. And certainly patients have good results when we do a good job of doing so. So it's really all about the energy and why discs don't fail because of abnormal motion. Discs fail because of excess energy transfer to that it cannot handle based on its design. I kind of alluded to this before. This is my energy theorem. So I kind of said that trauma is nothing more than an excess kinetic energy transfer causing injury. And if you think about it, this is a common concept. So even radiation energy, if I ask you what a gray was, it's nothing more than a joule per kilogram of tissue of radiation energy. And guess what? A joule is a Newton meter. Therefore, it gets back into the idea of the force deflection curve, which is force on the y-axis, displacement on the x-axis, and it gets you to your Newton meter units as well. And so that's the biomechanical pain hypothesis, which is about minimizing the amount of energy or excess energy causing tissue damage across that motion segment or construct. Very similar to choices of rod systems or implant, where you want to look at the various material properties and looking at the stiffness and yield point. And so, for example, if you try to choose a quarter-inch 635 or commercially pure titanium, what you realize is that depending on the manufacturer, that may actually have a lower yield point than their 5.5 commercially pure titanium. So you can't make the assumptions of thicker rods or different artificial disc implants will have different strengths without really understanding the material properties and based on the material data sheets that are provided by the manufacturer. So one of the things is it's a myth that arthroplasty can replace ACDFs. I think arthroplasty has a key role, but a lot of it has to do with the surgeon understanding what they're trying to accomplish for that specific area. And again, just to kind of highlight that heterogeneous biomechanical needs and degenerative disease, especially based on the levels that you're trying to treat, really requires you to have a large armamentarium. So I would definitely agree with what I said before, that you do need to learn all these various techniques to have tools in your armamentarium for treating patients surgically, and then really pick the best tool for that patient's pathology that you're trying to mitigate. So again, surgical skill does not replace the idea of surgical diagnosis and judgment, which is why I think a course like this that you're attending is key to help understanding a lot of that. So in conclusion, ACDFs are still the gold standard, but arthroplasty certainly is picking up a lot of steam. I think that arthroplasty has a very important role as far as what we can offer patients with certain pathologies moving forward. And it really is important to understand the diagnosis of the pathomechanics in order to really choose the best and the proper surgical reconstruction. So with that, I want to say thank you very much and let me give this presentation to you.
Oh, that's outstanding. That clearly was one of the most comprehensive reviews I think I can recall on arthroplasty. I have one quick question. We'll open it. You talked a lot about the failure of these implants, but what I see is not necessarily a failure of the implant, is really a failure for we look back and was it the ideal technique rather than the actual implant that tended to fail? Any thoughts on that?
Yeah, that's a great question, Mike. And I think it's all the above. Like I said, if you have the surgical technique and you're taking down the surrounding ligaments, and that's what I was kind of alluding to before, and, as you and I being, working with the AO about the principles, is really understanding what are some of the principles of stability across that segment. So for surgeons that really take down the bony and cartilaginous end plates, they're going to need to think about what type of load bearing that surfaces now can handle after you do that. Or if you take down the joints of Luschka, the uncinate joints, and increase the instability of that area in order to get your implant in. It's also one of the reasons why most of the recommendations is to undersize the implants, because unlike a fusion, you're not going to gain stability over time for your artificial disc. You're going to get what you get, and all it's going to do is just be a little stickier. But unlike a fusion, it's not going to gain strength over time.
Fantastic.
Hey, Mike, can I ask one question? I know we're behind time.
Yes.
Joe, thank you for joining us. Outstanding as always. Amazing Renaissance man. Question, do we need level-specific disc arthroplasties, and do we need to consider the mechanical device features in terms of connective tissue laxity of a patient, i.e. more lax patients need lower disc heights or more restrained disc or less restrained disc? And do we need different kind of mechanics for different levels, i.e. C3-4 versus C6-7 or C7-T1 even?
Mm-hmm. So that's a great question, Jens, about the needing. We know from gender-specific orthopedic implants that it became a little bit too specific, and you may not have needed it to that level of degree. But I do think that there is a role in the various types of motion-preserving devices based on the motion of that segment and the load bearing. So, for example, at C6-7, you're probably not going to need as much the relative motion as you might need something that's going to be able to handle the weight above it. I always tell people, using the rule of thumb, like in the lumbar spine, I usually use a rule of thumb of 75% of your body weight is going to be carried across that L5-S1 junction, just because it has no other choice but to have the weight go through it. And the same thing's going to be in a cervical spine based on the skull weight. So based on the patient's bone biology, based on the patient's overall body weight, I would say that we probably need to look at different types of implants that may be used. So for example, if you have the Charté with a cord that's spit out at L5-S1 with a high sacral slope or slip angle, that's a situation where if we had a more constrained device to be able to handle a patient with a large BMI, say 35 versus somebody with a 28, that's when you're going to need to think about what type of devices are going to be available and how do you predict what type of loading that you need to put in that area, just as an example. So, but the short answer is I do think we need to improve the availability of the implant choices based on the biomechanics of that segment that we're trying to stabilize and support.
Fantastic.
Thank you, guys. Mike, thank you very much for moderating, and thanks for our speakers.
Great. Thank you very much. Have a great day, everybody.
All right.